Hi friends, a very interesting bunch of radiology related questions that appeared in the recently conducted INI-CET exams. Let us quickly go through them. As we go through these particular questions, remember this discussion is not to make you feel good or bad or whether you got these questions and there are rather their answers right or wrong in the exam. No, that is not the purpose. The exam is gone and done. It's done, right? What lies in front of you, what lies ahead of you very soon is the next upcoming exam that you're going to appear for. And the purpose of these discussions is to quickly revise these particular topics, revise the allied topics, the related important concepts related to these topics. Therefore, if you get a repeat or a related question to these particular questions which are asked, you should definitely be able to crack it. Now, let us look at this question related to contrast agents. Now, they asked which of the following contrast agents is safe to use in renal failure patients? Is it gadolinium? Is it ionic contrast, iodinated or iodinated contrast, ionic or non-ionic? Is it ultrasound contrast? So, what we will do in the next 5 minutes is we'll quickly go through the basics of these various contrast media. And as we come to the end of this quick revision of contrast media, we'll get very close to the answer of this particular question. So, what are contrast agents? Contrast agents are nothing but these are agents which are used to enhance the appearance of a particular organ. So, barium is used to enhance the appearance of the esophagus, so it is a contrast medium. Iodine is used to enhance the appearance of the kidney, ureter, bladder, so it is a contrast agent. So, barium, ionic iodinated contrast, USG contrast, non-ionic iodinated contrast, gadolinium are the various contrast agents we need to know. So, these are the various contrast agents that we need to know. Now, about barium, barium we all know is used for basically GIT related studies. So, GIT tract studies, it is administered orally and it remains within the lumen of the bowel. So, there is no question of barium being nephrotoxic because it is simply not absorbed from the lumen of the bowel, right? So, therefore, barium we all know, which is used for barium swallow, barium meal follow throughs, barium enemas, right? It stays in the lumen of the bowel, shows the mucosal details, luminal details, right? And that is where it is used. It is not, there's no question of barium being nephrotoxic because it is simply not absorbed from the lumen of the bowel. The other contrast agents, because they are administered intravenously, they may be they need to be excreted out of the body, right? Either through the kidneys or metabolized by the liver or through the lungs. And therein lies the key. That is the answer to this particular question. Which of them are nephrotoxic and which of them are not? So let us quickly first discuss these iodinated contrasts. So iodinated contrasts can be classified as high osmolar, low osmolar. Under high osmolar, there is one subtype which is called ionic monomers. Just look at these two words, ionic and monomers. We are going to do a permutation and combination of these terms. So, under low osmolar contrasts, you'll find three subtypes, ionic dimers. Now switch to non-ionic. So, you have non-ionic monomers, non-ionic dimers. Remember, if you look at the toxicity profile of these iodinated contrast media, remember these high osmolar contrast agents, they are highly toxic. So you'll find a greater degree of adverse effects, be it related to their osmolarity, be it related to the nephrotoxicity when you use these contrast. Whereas these low osmolar contrast agents, these are relatively less toxic. Yes, if you consider these individual subtypes, therefore, it would automatically mean that these ionic monomers, which is a subtype of high osmolar contrasts, these are the most toxic contrast agents. Whereas in this order, as you go to ionic dimers, non-ionic monomers, non-ionic dimers, the toxicity decreases. This subtype, non-ionic dimers, is called iso-osmolar contrast agent, which means iso means same. So its osmolarity is similar to that of human serum or plasma. So non-ionic dimers, relatively, they are the least toxic. They are the least toxic ones. Now, the most important adverse effect related to iodinated contrast is called as contrast induced nephropathy. So they are toxic to the kidneys. That is the most important adverse effect related to iodinated contrast. So contrast induced nephropathy, how do you define that? You inject iodinated contrast because these iodinated agents are inherently toxic to the kidneys. So what will happen? The patient will go into renal dysfunction, renal failure. So how do you diagnose it? the diagnostic criteria revolves along measurement of serum creatinine. So there is an increase in serum creatinine. By how much should serum creatinine increase? It should increase by either 25% or an absolute increase of 0.5 milligram per deciliter within 48 to 72 hours of IV contrast administration, right? So IV contrast, injection of the contrast, right? So this is what is the diagnostic criteria of contrast induced nephropathy. What are the various markers used for diagnosis? So one marker we have already seen is serum creatinine. So first marker is serum creatinine. Another marker which can be used for diagnosis is called serum cystatin C. Estimated glomerular filtration rate less than 60 ml per minute, right, is also a marker. And there is a novel biomarker which is used, which is called as plasma NGAL, that is neutrophil gelatinase associated lipocalin. So neutrophil gelatinase associated lipocalin, this is a new biomarker which has a better predictive value. What are the risk factors for the development of contrast induced nephropathy? Remember, they can ask you specifically what is the single most important patient related risk factor. So single most important patient related risk factor is pre-existing is pre-existing chronic kidney disease. Pre-existing chronic kidney disease. So patient is already a patient of renal failure, chronic kidney disorders, right? And you inject iodinated contrast, then there is a very high likelihood that the patient will develop contrast induced nephropathy, right? And therefore to prevent it, we must first do a renal function test before we inject iodinated contrast. So this is a very important principle. Other principles, right, other risk factors which are the usual risk factors such as elderly age, diabetes mellitus, multiple myeloma, dehydration, right? So these are metabolic syndrome. So these are important risk factors for the development of contrast induced nephropathy. Well, contrast induced nephropathy, remember, is a self-limiting disorder in most cases. So all the treatment that is needed in most of the cases is just supportive treatment. Supportive for what? Supportive for fluid and electrolyte balance. So all you need to do is to maintain the fluid and electrolyte balance, right? That is all that is needed in most of the cases. But sometimes if the renal dysfunction is severe, you may have to perform hemodialysis, right? But that is very rarely required. Most likely it is just supportive treatment which is needed. That is all that is needed. Very important is to prevent the development of CIN, and we have already discussed one strategy for prevention of CIN. What is that? It is pre-contrast, yes, renal function tests, because the most important patient related risk factor for the development of CIN is pre-existing chronic kidney disease. We must do a renal function test, serum creat value, blood urea nitrogen, before we inject contrast, so that we inadvertently don't inject it in a chronic kidney disease patients. Another way of preventing is pre-contrast hydration of the patient. Never inject contrast in a dehydrated patient. That is, dehydration is a risk factor. It will aggravate the renal injury. Vitamin C can be used for prevention. Bicarbonate therapy can be used. N-acetylcysteine, N-acetylcysteine, right, is a renoprotective agent with sulfhydryl group. It protects the kidneys from damage. Certain statin drugs such as rosuvastatin is also considered to have a preventive role for CIN. So now it is clear that iodinated contrasts are nephrotoxic. So in renal failure patients, we don't want to use them, whether it is ionic or non-ionic, right? Though non-ionic contrasts are less toxic, we've seen that, but still, as far as possible, we want to avoid it. Now tell me, if iodinated contrasts which are used in X-ray, CT scan cannot be used in renal failure patients, can in such patients can we do a contrast enhanced MRI? What is the contrast agent used in MRIs? It's gadolinium, right? Is gadolinium nephrotoxic? The answer is no, it is not. So can it be used in renal failure patients? Well, the answer is no. and I'm coming to that. Remember, gadolinium is the most common MRI contrast agent which is used. It could either be gadolinium is an example of, remember, a T1 relaxation agent. So T1 relaxation agent, gadolinium, what do? They cause T1 shortening. So the appearance is bright on T1 weighted images. So gadolinium is the most common MRI contrast medium. It is a T1 relaxation agent, causes shortening of the T1 relaxation time. As a result, the tissue appears bright on T1 weighted images. T2 relaxation agents is another type of MRI contrast medium, right? They are less commonly used. One example is super paramagnetic iron oxide. Super paramagnetic iron oxide is an example of T2 relaxation agent. It causes shortening of the T2 relaxation time. As a result, the affected organ, the involved organ, it appears dark or hypointense on T2 weighted images. This particular group, this particular contrast agent SPIO is taken up by the Kupffer cells in the liver, and Kupffer cells are abundant in a liver focal lesion called as focal nodular hyperplasia, and as a result of which, for FNH diagnosis, this SPIO T2 relaxation agent can be used. So coming back to our question, can gadolinium be used in renal failure patients? No. Is it nephrotoxic primarily? The answer is no. But it gives rise to, yes, so we have seen this T1 and T2 relaxation agents, it gives rise to what is called as nephrogenic systemic fibrosis. So nephrogenic means the origin is because of the kidney, that is kidney failure. So what happens basically here is that when you administer gadolinium as a contrast agent, this gadolinium is excreted out of the body. It is excreted out of the body by the kidneys. And when there is renal failure, will gadolinium be excreted out? No. So this gadolinium stays in the body for a very long period of time. So this gado part of that compound, it gets therefore deposited deposited into the soft tissues of the body. It gets deposited into the soft tissues of the body, where it creates an inflammatory response. Reaction gives rise to nodules, thickening, contractures, deformities, ultimately death. So this is called nephrogenic systemic fibrosis. The most common agent associated with nephrogenic systemic fibrosis, remember, is gadodiamide. Omniscan, it is banned. Others are gadopentatide dimegloline, gadovercetamide. Recently, these group of contrast agents, they have been classified as gadolinium group 1, and this cannot be used in renal failure patients. There are certain agents of related to gadolinium which are classified as gadolinium group 2 and group 3. These group 2 and group 3 agents are considered to be safe even in renal failure, right? But in your question in the exam, there was nothing mentioned about group 1, group 2, group 3. It was just gadolinium, and therefore primarily we don't know what group they are mentioning, so it should not be used in renal failure patients. What about ultrasound contrast agents? Ultrasound is a mechanical wave compression rarefaction, right? So the contrast agent which is used in ultrasound, these are microscopic gas bubbles, right? First generation, there is gas without any shell around it, so they are unstable. If you inject it, by the time they reach the target organ, they will disintegrate. Second generation ultrasound contrast agents, they have a protein shell, so they are relatively longer lasting, but better, right? Most recent ones are third generation, where there is a gas, nitrogen, polyfluorocarbons, right? And there is a shell made up of proteins, lipids, or polymers. These are very stable, very long lasting, can effectively used for target organ imaging, right? So there is an increased stability as we go from first generation, second generation to third generation. Can you think about it and tell me, ultrasound contrast agents are excreted from the body through what organ? See, they are gas bubbles. And which organ in the body is involved in gas exchange? Yes, it is the lungs, correct. And therefore, remember, it is this group of contrast agents which is the safest one to be used in renal failure patients, because they are not going to affect, right, what, the kidneys. They are not going to damage the kidneys. They are not, nothing to do with kidneys as far as their excretion is concerned. They are not toxic, and therefore they are excreted from the body through the lungs. And therefore, now if we come back to this question, we have seen that gadolinium contrast agent used in MRI group 1 cannot be used in renal failure patients. Group 2 or group 3 could be used, but there is no detail regarding the group of the contrast agent which is mentioned here. We know iodinated contrast agent, most important adverse effect is contrast induced nephropathy, cannot be used in the renal failure patients. That is the most important risk factor. Rather, we have seen ultrasound contrast agents, yes, they are excreted from the body through the lungs. This is going to be the answer in the for this particular question. So that is going to be the safest one to be used. Yes. So Mount Fuji sign is seen in which of these conditions? So all the options, you see some tension, 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 and pneumo, 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 pneumo. So let us quickly look at pneumo means what? Pneumo means air. So let us look at various situations in the body where you will get an abnormal accumulation of air. So when there is an abnormal accumulation of air, right, when you find air within the mediastinum, see, in the anterior mediastinum as well as within in the, around the great vessels there, right, this is what is called as what? This is called pneumomediastinum. Pneumomediastinum mainly is a result of trauma, so from rib fractures and lung injuries. So you can also see some air within the chest wall. So this is also called subcutaneous or chest wall emphysema there. This is pneumomediastinum. Well, air within the pleural cavity, right? Air within the pleural cavity. Normally, inside the pleural cavity, there is a thin rim of fluid. Air accumulates in the pleural cavity. This is called as pneumothorax, right? And when air enters into the cranial cavity, can you see this jet black area here? This is what is called as pneumocephalus. Now, in any of these closed spaces, when this air is at a very high pressure, right? Though we cannot really measure these pressures when we do radiological investigation, we need to do manometry, or we need to put a pressure measuring probe to actually measure the pressure. The indirect radiologic sign that is going to tell us that this air is at a very high pressure is mass effect on the adjacent organ. Whenever you see that the air is at a high pressure, because you see mass effect, you call it as tension pneumomediastinum, tension pneumothorax, or tension pneumocephalus, right? So tension means high pressure. And then remember, always, 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 this is a surgical emergency. This is a surgical emergency that needs to be treated very rapidly. If they ask you what could be the investigation of choice for any of these conditions where you find abnormal air within a particular space, remember the concept, fluid is friend of ultrasound. So wherever in the body you want to detect fluid, the investigation of choice will be ultrasound, like pleural effusion, right, like pericardial effusion, like fluid within the peritoneal cavity. But air is enemy of ultrasound, remember. And here you, if you, therefore it means that wherever you want to detect air in the body, air is enemy of ultrasound. Ultrasound won't work. So use the next best investigation, and therefore it is always, always, always going to be a CT scan. So it is always going to be a CT scan. So fluid is friend of ultrasound. For fluid anywhere in the body, use ultrasound. Air is enemy of ultrasound. So to detect air anywhere in the body, you cannot use ultrasound. Air is enemy of ultrasound. So therefore you use the next best investigation, and that is CT. Okay. Now we come to pneumocephalus. So what is pneumocephalus? Air within the cranial cavity or the cranial vault. So as you can see here, inside the cranial vault, around the brain, you see this jet black appearance, that is air. Most common cause for pneumocephalus, remember, is trauma followed by surgery. So if the patient has undergone a surgery, say a craniotomy or a brain related surgery, say brain tumor excision surgery, then you may expect a little bit of pneumocephalus immediately post surgery if you do imaging there, right? In trauma, remember, it is mainly injuries involving the frontal bone, because there you have the frontal sinus, and that is the most common site of entry of air within the cranial cavity. Most commonly, right, in the initial stages, right, when the air is minimal and at low pressure, the patient may be asymptomatic. But as the amount of air as well as the pressure increases, the patient may experience headache, and this may progress to signs of raised intracranial tension. There is a term which is called as Bruy hydroeric, which means when there is a lot of air inside the cranial cavity, right, it is in the subarachnoid space where which also contains CSF. So if the head of the patient is moved and you auscultate, you try to listen, you may hear a splashing sound. So and you may hear actual splashing kind of a sound because of the admixture of air and the CSF when the head is moved, physical movement motion of the head. This is called Bruy hydroeric. Now see here, various imaging appearances have been associated with pneumocephalus. See here, can you see all this tiny bubbles, right, of air scattered right around the brain? This is what is called as the bubble sign. This is called as the bubble sign related to pneumocephalus. But when the air is at a very high pressure in tension pneumocephalus, the appearance of the brain, the brain is compressed, so it appears pointed like this. This resembles the appearance of Mount Fuji, which is an active volcano in Japan. So this, kind of a pointed appearance is what is called as Mount Fuji sign. This is a feature of not just pneumocephalus but tension pneumocephalus. Tension means high pressure, it is compressing the underlying brain parenchyma. Another sign which has been described is what is called as the peaking sign, which is a similar appearance where there is a pointed appearance of the brain. And in Mount Fuji, along with the peaking, there is also a wide separation of the brain parenchyma, right? So as you can see here, the brain parenchyma is slightly separated, the two frontal lobes away. That is because of the high pressure of the air. So bubble sign, peaking sign, and Mount Fuji sign, these are signs that have been described in tension pneumocephalus. So tension pneumocephalus, remember I told you, do you remember whenever you see this word tension, remember that this is a surgical emergency, right? So we might have to do a burr hole craniotomy. So burr hole craniotomy to remove the air, or rather relieve the pressure component, tension component of the pneumocephalus. Gradually the air would then decrease, but the pressure component causing mass effect on the brain is something which is going to adversely affect the condition of the patient. Sometimes it can be associated with a CSF leak as well, right? And then that also needs to be treated definitively. So tension pneumocephalus, tension pneumothorax, tension pneumomediastinum, right? It is considered to be a surgical emergency because of the high pressure at which the air is there. So Mount Fuji sign is seen in, we have seen Mount Fuji sign is a feature of tension pneumocephalus, that is air within the cranial cavity at a very high pressure. Yeah. All right, now let us look at this CT scan related question. Which of the following statements is correct about CT scan? So different topics related to different concepts related to CT scan is what they have included in these options. Let us quickly go through the basics of CT scan and then we'll come back to this particular question. So what is CT? CT machine basically comprises of two components. One is the computer. So this is computed. T stands for tomography. Yes. So as we can see here, the CT department has two parts. Basically, the CT equipment room where the tomographic unit is kept. There's a gantry and a table, and the CT console where the computer is kept, and the computer is going to do all the image processing of the data. Around the CT equipment room, there is going to be a lead lining. Why? To prevent the leakage of radiation. So this lead lining is going to prevent the leakage of radiation, right? It is around 1/16th inch of lead, or around 4 to 6 inches of standard density concrete is what is used to block the radiation beams to prevent leakage from the CT equipment room. Now, what is the basic principle of CT scan? The basic principle of CT scan states that the internal structure of an object can be reconstructed from multiple projections of that particular object. If you see this unit, this is a gantry and a table. The patient is lying on the table, and this particular table then slides inside the machine, and that is how the CT scan actually works. If you stand at the foot end of this patient and you face towards the machine, you look at the machine from the front, this is how it would look like. Let us open it up. What lies inside this particular machine is that you have that small round area that you see at the top. Yes. What is that? That is an X-ray tube. What is the function of an X-ray tube? It is to produce an X-ray beam. So an X-ray beam is going to cut across a slice of the patient's body, right? And this is going to be detected by these electronic detectors that lie on the other side. So see what happens when a CT scan is done, right? When a CT scan is done, a filtered X-ray beam. Why filtered? Because to remove the low energy X-ray beam which is going to create noise, this X-ray beam is a filtered beam. It cuts through a slice of the patient's body. It is detected by these detectors. Remember, I told you these are electronic detectors, right? So they are going to collect electronic data. So this electronic data is given a name. So these electronic detectors, the data that they collect, it is given a name. It is called as the first projection data. So this first projection data is then transmitted to the computer. So there are two parts of the CT machine we saw, computer and tomography, right? So this first projection data is transmitted to the computer is going to process this data, analyze this data. So two parts of the machine we have seen, the computer is going to apply a lot of mathematical algorithms on it. This process is repeated. Now see what happens inside the CT scan unit is that this X-ray tube which is there around the patient's body, now it is going to move to a new point along the circumference of the ring around the patient's body. So if you look at the animation now, it is at a new point, the detectors are at a diametrically opposite position, new position. Same process is repeated, right? The fan shaped X-ray beam is cut across the patient's body, right? Again, a image is created, right? This data is called projection number 2. It will look different from projection number 1 because it has been taken from different angle around the patient's body, right? So projection number 2, again the data is fed to the computer. So this process is repeated, right? So we will obtain the third projection, fourth projection, right, fifth projection, n number of projection data is obtained, and all this projection data, right, is fed to the computer. Now what the computer does basically is there's a lot of data that the computer receives. So the computer processes this data, and ultimately at the end of that data processing where a lot of mathematical algorithms are applied, what happens is on the screen of the computer, right, we will be able to see a CT scan image. That is how the CT scan image is reconstructed. Now let us look at a sample image. Suppose that we are scanning the thorax of this particular patient's body. So what do you see here, right? Inside this image, we are able to see what are the various structures inside the patient's body. So what can you see in this particular structure? If you look anteriorly, there's the sternum, you're able to see the heart, you're able to see the lungs. So if you look at this particular image carefully, it is showing you the chest wall, right lung, left lung, the heart, aorta, vertebral body. So what this image is actually showing you is what? It is the internal structure of the patient's body, isn't it? And this internal structure has been reconstructed from what? This internal structure that we are able to see is being reconstructed from n number of projections of that particular patient's body, isn't it? What is the basic principle of CT scan? The basic principle of CT scan is that the internal structure of an object can be reconstructed from multiple projections of that particular object. Now that we know the basics of CT scan, let us look at what is the Hounsfield unit scale or a CT value scale. On a CT scan image, each and every tissue in the body is given a numerical value. This numerical value given to that particular tissue is called as its Hounsfield unit value or CT value. How is it calculated? It is calculated as Hounsfield unit value of that tissue X is equal to 1000 multiplied by mu of X minus mu of water divided by mu of water. Just put X as water. So if you put X as water, look at the numerator here. Mu of water minus mu of water will be 0. You divide it by anything, you multiply it by anything, the answer will be 0. And therefore, if you look at the Hounsfield unit scale, at the center of the scale at 0 HU, you will find water. This was a part of the one of the options in this question, isn't it? This is the negative side of the scale where all the tissues which are less dense than water will lie, namely least dense component of the body is what? It is air at around minus 1000 HU. Close to it, you will find lungs at around minus 800 HU, and fat is somewhere over here at around minus 100 HU. This is the positive side of the scale where all the tissues in the body which are denser than water will lie. On the positive most extreme, you have the densest tissue component in the body. What is that? Yes, correct, bone. at a Hounsfield unit value of plus 1000 HU. Almost all the soft tissues in the body will lie between that of water and bone. One important tissue I want you to know is what is called as acute hemorrhage or bleed within any organ. So acute hemorrhage lies somewhere over here with a Hounsfield unit value of around plus 45 to 65 HU. This is all that you need to know about the Hounsfield unit scale. Let us quickly go through the various radiation exposures in various investigations. If you remember this as a routine table and try to mug it up, it is going to be very difficult for you to remember. So we will not do that. We will use a color scale. We know green is good, yellow is a warning, red is danger, isn't it? So we will classify the various X-ray based imaging modalities into green zone modalities, which are called spot radiographs. X-rays, basically one exposure, two exposures, AP lateral, right? They are relatively safe. Why? Because they have a lower radiation exposure. Above it are diagnostic procedures like IVU, MCU, barium enemas. Because they have multiple exposures occurring to the patient's body, they have a relatively higher exposure. It is like a warning. And remember, the red zone comprises of CT scan, PET scan, and radionuclide studies. It has very high radiation exposure. So, red zone, it is dangerous. We are supposed to know. So, as you go from green zone, yellow zone to red zone, it is obvious that the radiation exposure is going to increase. This exposure that we are going to study is going to be in millisieverts. So I want you to remember a few important radiation exposures. Remember, spot radiographs are what? X-rays basically. So limb X-ray, joint X-ray has an exposure of less than 0.01 millisieverts. Chest X-ray PA view has an exposure of 0.02 millisieverts, whereas lumbar spine has an exposure of around 1.0 millisieverts. Remember, these are important. In diagnostic procedures, remember minimum and maximum. So MCU, micturating cystoerythrography, has a radiation of exposure of around 1.2 millisieverts, whereas barium enema has a radiation exposure of around 7 millisieverts. In red zone, remember CT scan exposures, very, very important. So if you look at CT scan exposures, remember CT scan head has an exposure of around 3.5 millisieverts. CT scan thorax, let us complete the discussion of all CT scan exposures. So CT scan thorax is around 8 millisieverts, CT scan abdomen is around 10 millisieverts, and PET scan, remember, is around 25 millisieverts, the maximum of all. So green zone, yellow zone, red zone, we have studied the concept, spot radiographs, diagnostic procedures, CT, PET radionuclide studies, and we have studied few important radiation exposure values. Now let us come back to this question. Let us see, look at the options. Which of the following statements is correct about CT scan? CT score of water is 0. This is correct. Hounsfield unit value, do you remember the value? We discussed the first thing that we saw at the center of the scale at 0 HU is water. So this is correct. CT consists of unfiltered X-ray beams. No, this is wrong. I told you the beam is always filtered. Why? Because we want to remove the low intensity X-ray beams, because they are unnecessarily going to add noise to the image. So we are going to remove that. CT scan is an investigation of choice for gallstones. It's also wrong. Why? CT scan is the investigation of choice for renal or ureteric calculi. Why? Because renal and ureteric calculi, the most common renal or ureteric calculus is what? It is calcium oxalate, and because it contains calcium, it is dense, and therefore because of its density, it appears hyperdense or white on CT scan. Therefore, CT scan is the investigation of choice for renal or ureteric calculi, calcium oxalate. Is it the same for gallstones? No, gallstones or biliary calculi, the most common composition is what? They are mixed calculi, meaning they have very, very low calcium content. And because of this low calcium content, remember, right, these biliary calculi, many times they are just not visible on CT. And that is the reason why the investigation of choice for gallstones is not CT, it is USG. Remember. So this also is incorrect. Non-contrast CT head has a exposure of 20 millisieverts is also wrong. Do you remember? We discussed CT head is 3.5 millisieverts, CT thorax is 8 millisieverts, CT abdomen is 10 millisieverts, and PET scan or PET CT is 25. So if you look at all the options carefully, we have studied CT scan and X-ray exposure basics in detail here. We have seen many concepts, and the answer here therefore is going to be A. CT score of water is 0. Yes. Now, where is this arrow pointing? Well, this question is not actually a new question. Why? It has been asked twice before. Once in an INI-CET exam, where the underlying concept was the same, though the diagnosis was slightly different, and in an FMG exam before, where the exact same question was asked. So basically, this question is asking you about the concept or technique of identifying ribs on a chest X-ray. We have studied that in chest X-ray basics part of our video. So anterior versus posterior ribs. How does a rib begin? Rib begins posteriorly. It has a round head which articulates with two hemifacets on the lateral surface of two adjacent thoracic vertebral bodies, forming a complete facet. Then it articulates with the tip of the transverse process. Then it goes around the thorax as it comes anteriorly. Most of the anterior ends of bony ribs, they end away from the sternum. There is a gap between the anterior end of rib and the sternum, and this gap is bridged by the costal cartilage. So posterior ends of ribs, remember, they are always closer to the midline, whereas anterior ends of ribs, they are always away from the midline. If you look at this X-ray, therefore, if you see all these ends of ribs, what are these ends? They are all posterior ends of ribs. If you look at the direction or orientation of these ribs, you will realize that all of these ribs, they are more or less horizontally oriented. Whereas if you look at the anterior ends of ribs here, which are away from the midline, and look at their orientation, are they horizontal? No. So anterior ends of ribs, they are away from midline, and as you can see here in this image, they are obliquely oriented, right? So let us quickly summarize. Look at the image there. Posterior ends of ribs are closer to midline and horizontally oriented. Anterior ends of ribs are away from midline, they are obliquely oriented, right? One important application of this is to identify whether a chest radiograph is inspiratory radiograph or expiratory radiograph. What is the criteria to do that? Right, as the diaphragm contracts in inspiration, it goes down, more and more number of ribs are seen above the dome of diaphragm, so we count them. The criteria is that you must see at least 10 posterior ends of ribs or at least 6 anterior ends of ribs above the dome of diaphragm to say that it is a good inspiratory radiograph. You can count it here, and you are able to see more than 10 and more than 6 anterior ends of ribs, more than 10 posterior ends of ribs. So this is a good inspiratory radiograph. So this was the question in your exam. They had put up an arrow and asked you what particular part of rib it is. Well, the question which was asked previously in one of your INI-CET exams last year was this. So look here, identify the fracture site, right? It's one of the same, more or less the same concept. You identify where the fracture is, it posterior end, anterior end, what part of rib it is. And the number of ribs is simply identified by counting the number of ribs from the top. Let us count the ribs here. See, this is the first rib. This posterior end that you see is the second rib. So this is the third, this is the fourth, this is the fifth, this is the sixth, this is the seventh. So which rib is fractured? Sixth rib is fractured, seventh rib is fractured. So the answer to this particular question in last year's exam was there is a fracture involving the sixth and the seventh, close to the posterior end than the anterior ends because it is closer to the midline, right? Now, yes, so rib fracture specifics, maybe next time they ask you one of these clinical pointers. Remember, rib fractures are the most common injury which is seen in blunt thoracic trauma. Preferred investigation, they may ask you. Remember, the investigation of choice is always going to be CT, right? Ultrasound, when it is used as point of care ultrasound. What is focus? Point of care ultrasound, where ultrasound is used in the emergency department, that is casualty, at the bedside. It has some practical value because emergency life-threatening diagnosis can be made very fast. Treatment can be done then and there. Patient's life can be saved. X-ray, though it is used, it is not very sensitive. So least to best, most useful investigation is X-ray. Better than X-ray is USG when it is used as POCUS, point of care bedside ultrasound, right? And best overall is CT. Yes. Usually, rib fractures associated with very high energy trauma are first to third rib fractures. Remember, rest of the ribs can get fractured even with minimal trauma. So, which of the following structures is the arrow pointing to? If you see here, the arrow is pointing over here. What is this? This is the end of rib which is obliquely oriented and it is away from the midline. So, it is pointing to the anterior end of the rib. Yes. So, this is where it is pointing to. Now, identify the normal anatomic variation given in the following CT image. Now, a tracheal diverticulum or esophageal diverticulum, right, would likely contain either air or fluid. So, tracheal diverticulum will contain air, esophageal duplication, right, could also contain, if there is a cyst which is formed there, it could also contain air or it could contain fluid. Look at this arrow. The arrow is pointing to a very hyperdense structure. It is as hyperdense as blood vessels there. Look at the branches of the aorta. A right aortic arch, yes, it could mean that it could be it could appear bright like this because it contains contrast. Aberrant right subclavian artery is also possibly could be the answer because it looks like a blood vessel. But what anatomic level are we? We are at the level of the trachea. We are not yet able to see the aortic arch. We are barely able to see the SVC and a few branches of the aortic arch. Just ignore this structure, right? This is an artifact. Either it is the dilated brachiocephalic vein or an anterior mediastinal lesion there. Just ignore it. Look at the SVC. So, this is the SVC and the three branches of the aorta. So, if we are above the level of the arch of aorta, should we be able to see the aortic arch at this site? No, we are above the level of the aortic arch and therefore it cannot be the right aortic arch as well, right? And therefore the answer here is aberrant right subclavian artery. What is aberrant right subclavian artery? Let us look at this graphic. If you remember this graphic, you have seen it in my video lecture of coarctation of aorta, which is narrowing of the aorta. Can you see it there? So let us, I have used it here so that we can quickly look at the various branches of the aorta. What are the branches of the aorta? So this is your brachiocephalic trunk. So brachiocephalic trunk is going to divide into the right subclavian and your right common carotid artery. The second branch is the left common carotid artery arising from the aortic arch, and the third branch is going to be the left subclavian artery. And we had discussed that the most common site of coarctation, that is aortic narrowing, is postductal, distal to the ductus arteriosus. So this is the narrowing. There was a particular situation there we had discussed where I told you that the brachiocephalic artery is absent, the right subclavian artery therefore is absent, and the first branch that arises from the aortic arch is the right common carotid artery, followed by the usual branches left common carotid artery and the left subclavian artery, but the right upper limb has to be supplied blood, isn't it? So then there is an aberrant course or an abnormal course of the right subclavian artery which arises distal to the left subclavian artery, arches behind these arterial branches, goes behind the trachea, and this is your aberrant right subclavian artery on URSA. Right? Did you understand what is URSA? From where does it arise? It is an abnormal branching pattern of the aortic arch. It is the abnormal course of the right subclavian artery when it arises distal to the left subclavian and arches behind these arteries. When it loops behind the artery, it has a peculiar relationship with the trachea and the esophagus. So if you look at this CT image now, this is right, this is left, correct? So this is the SVC, right? This is the brachiocephalic. You can see the aortic arch going from the right to the left. This is the trachea. This is going to be the esophagus over here. And there is a branch of the aortic arch, which is right arising from the distal aortic arch, traveling towards the right side behind the trachea and the esophagus. And this is your aberrant right subclavian artery, right? Now, if you look at this image, it is showing you more or less the same findings. This is the SVC. This is the aortic branches. So, this is going to be your right common carotid, left common carotid, and left subclavian, right? And you see a branch because you're above the level of the aortic arch now. You're not seeing the aortic arch, you're seeing the branches. You see an artery which is located behind the trachea and possibly the esophagus over here, right? And this is nothing but your apparent right subclavian artery. Now, few of you may wonder that if it is passing like this towards the right upper limb, it should be seen longitudinally. Why are we seeing a cross section over here? Well, the reason behind that is that if this artery is not traveling perfectly in the horizontal plane, suppose this artery is traveling somewhat like this to the right upper limb and I take a cross section over here, I am going to see a cross section of the artery over here, and that is why it is looking like a cross section there. Okay, so this is your aberrant right subclavian artery. What is the importance of detecting it? So few important applications of detecting, importance of detecting the aberrant right subclavian artery. There could be variations in its course. In 80% of the cases, it passes posterior to the trachea and the esophagus. Okay, in about 15% of cases, it passes between the trachea, it passes between the trachea and the esophagus, that is behind the trachea, anterior to the esophagus, and just in about 5% of the cases, it passes anterior to the trachea. Whenever it passes posterior to the esophagus or anterior to the esophagus, that is 80% and 15%, that is the course, it can compress the esophagus and give rise to dysphagia. So this is also called as arteria lusoria, and the dysphagia that it causes is called as dysphagia lusoria, right? Because of the compression of the esophagus. So it can be associated with what? It can be associated with trisomy. So trisomy 21, trisomy 18, trisomy 13. So antenatally, when we do fetal ultrasounds, we look for apparent right subclavian artery is an aneuploidy marker. If it is associated with any other marker, then we have to go ahead and do invasive testing amniocentesis for that fetus. Yes, there is a term which is called diverticulum of Commerell. What is that? It is a fusiform dilatation. So, a fusiform dilatation of proximal most portion of aberrant right subclavian artery. This pouch-like dilatation, fusiform dilatation of the proximal part of this aberrant right subclavian artery is called diverticulum of Commerell. Remember, because of the embryological variations here, in cases of ARSA, the right laryngeal nerve is not recurrent. So it enters the larynx directly, right? Enters the larynx directly. This has immense surgical importance. It is not recurrent. That is, it doesn't go down, dip down into the thorax and then come up, but it enters the larynx directly. It has surgical importance. What is that? We are going to see that. And of course, we've discussed this because it compresses the esophagus. So extrinsic compression of the esophagus is going to give rise to dysphagia. This is called dysphagia lusoria. So risks and complications, yes, if the surgeon is not available, not aware that the information is not available pre-surgery. The surgeon is not aware that there is an ARSA, and during esophageal surgeries, because of the close anatomical relationship, right, if the surgeon is not aware of there being an ARSA, it can give rise to torrential hemorrhage. It can give rise to recurrent laryngeal nerve injury in your thyroid, and parathyroid surgeries, because the course of the laryngeal nerve there is going to be non-recurrent. We studied that, right? Specifically right laryngeal nerve, and therefore during thyroid and parathyroid surgeries there could be an injury. So we come back to this particular image. We have seen this image. This is an artery traveling towards the right upper limb behind the trachea and the esophagus. So what is this? This is an aberrant right subclavian artery. We have not just discussed the anatomy, we have discussed from where it arises, how it courses, and what is the clinical importance of knowing that there is an apparent right subclavian artery, right? Now look at this. This was actually an easy question because we've already discussed this, right? What is this? This is a patient with stab wound, a supine X-ray, chest X-ray, APU was given. If this was pneumothorax, just see logically, pneumo means air, so it should have appeared lucent or black, isn't it? If there was pulmonary contusion, it would have given rise to a focal opacity and not a generalized opacity over the right hemithorax, as you can see here. If there was diaphragmatic rupture, you just could not see the diaphragm. The diaphragm was visible in this image. So what remains therefore is a diagnosis of excluding, after all of these three are excluded, is right hemothorax. Hemo because the patient had a stab wound, right? Why hemo? Because the patient had a stab wound. So hemo is what? Just blood, or rather fluid within the pleural cavity. Now let us quickly revise how fluid would appear, right, if it accumulates in the pleural cavity. If the patient is erect, small amounts of fluid will give rise to blunting of CP angle, isn't it? More amount of fluid, moderate amount of fluid, you will see a meniscus sign where you will see an opacity and you will see an ill-defined upper margin. This is called pleural meniscus sign. If there is a large amount of fluid, it would fill up the entire hemithorax. The hemithorax would be completely opaque. This is called opaque hemithorax. In the given radiograph, it was dense, but it was not opaque. If the patient is put into right or left lateral decubitus position, supposing this patient is kept into left lateral decubitus position, all the fluid would then settle along the new dependent part, that is the left lateral thoracic wall. So see here, this is your blunting of CP angle that we discussed, right? This is your pleural meniscus sign. Look at the graphics there. Can you see the meniscus sign? So that is the meniscus. This is your opaque hemithorax. Yes, so this is your opaque hemithorax that we discussed, right? But in the exam, it was not an opaque hemithorax. And see, this was the left lateral decubitus view, right? So this is how fluid would layer down. Now, just imagine what will happen if the patient is a patient of stab wound, critically ill, unable to stand because of the wound trauma. So patient was in a supine position. What will happen if the patient is in a supine position? Just look at the patient. This is the patient's thorax. From the sides, the patient is lying supine on the bed. In this supine position, the most deepest and dependent most part of the pleural cavity will be along the posterior thoracic wall, right? So this is anterior, this is posterior. So what will happen to the fluid or blood in the pleural cavity? It will settle down along the posterior thoracic wall like this, isn't it? In this patient, if I do a chest X-ray AP view, because it is a critically ill patient, don't you think all these X-ray beams will have to pass through this layer of fluid or blood along the posterior dependent part of the thoracic cavity, isn't it? So what will that result in? That will result in an increased density of the entire hemithorax. But if you look carefully, even through and through that increased density, you are able to see some vascular pattern within it. Can you see that? Why? Because the blood vessels over here, they are surrounded by air. This is air-filled lung, right? And therefore, you are still able to see some vessels. See, if I remove these annotations, can you see this hilar shadow here? You are able to see it inside, which means that the lung is otherwise okay, but there is a layer of fluid along the posterior thoracic wall. And we have discussed this finding when we discussed pleural effusion in the respiratory system videos, right? We saw this is how pleural effusion would appear on a supine X-ray. So therefore, on the basis of the history and the imaging findings that we just discussed, there is fluid within the thoracic pleural cavity along the posterior dependent thoracic wall. And because this is a patient of stab injury, yes, this is going to be hemothorax. So the answer here in this case is going to be right hemothorax. Yes. Well, friends, as I said, INI-CET May 24 is something in the past. What you are currently is you're working on your preparation at the present. But in this present, the importance of looking at these questions which have been asked in the past is to strengthen your preparation for the future. You might wonder what it would serve, right? At this time, it won't feel like much, right? But these individual questions, as we go through them, these small bits of information that you collect, you get better and better and better at all these topics. And ultimately, at the end, when you go through the recall of all these subjects together, you'll realize that it is going to result in a massive improvement in your preparation and in your performance in the exam. So keep on with the effort till the very last day, last hour, last minute of your preparation. Keep on preparing, keep on trying, and it is going to help you to get through this challenge with flying colors and get that dream branch of yours. We'll all get through this together. All the very best. Bye.